My name is Michael Gorin, and I'm a urologist at Urology Associates and UPMC Western Maryland, located in Cumberland, Maryland. Today, I'll be speaking about biomarkers for the diagnosis of prostate cancer. So for the last 30 years, prostate-specific antigen, also known as PSA, has proven to be a tried and true marker for the diagnosis of prostate cancer. PSA, also known as human killocrine-3, is a protease synthesized by the ductal and anastomal epithelial cells of the prostate. It's under normal conditions, it's secreted into the ductal lumina where it proteolyzes seminogelin. The normal architecture of the prostate usually contains PSA to the gland. However, in the presence of prostate cancer, PSA spills into the blood where it can be found at levels 10 times as high as normal physiologic levels. PSA was approved as a biomarker in 1986. And since then, the benefits of PSA screening have become quite evident. Starting in the late 80s and early 90s, with the adoption of PSA screening, we've seen a marked reduction in the incidence of men presenting with metastatic prostate cancer. And that's because the PSA marker has allowed us to detect disease earlier and earlier. While PSA has been found to be quite sensitive, there are limitations surrounding the specificity of this marker. In the United States, roughly 30 million PSA screening tests are performed. Approximately 1.5 million of those are found to be abnormal, and 1 million men will undergo a prostate biopsy. With that, however, only 250,000 men will be diagnosed with prostate cancer. And so roughly 750,000 men will have negative prostate biopsies. It is for these men that a more specific test would have benefited. There are risks associated with prostate biopsy, including infectious complications, resulting pain, missing work, etc. And so it's necessary to avoid biopsies in patients who do not really need one. So how could we do a better job in selecting men who need a prostate biopsy? Well, we have biomarkers now which are available which augment the specificity of PSA. Here's just a listing of them, and they include percent-free PSA, PCA3, the Prostate Health Index, also known as the PHI score, the 4K score, Select MDX, which is a urine-based test, Exodx, which is a urine-based test, now the MER Sentinel test, which was approved just several weeks ago, and also prostate multiparametric MRI. In terms of biomarkers as we conventionally think of them in terms of urine or blood-based, really the four worthy of mention are the PHI test, the 4K score, the Select MDX, and the Exodx EPI test. And that's because the NCCN guidelines currently endorse using these tests. I don't have time in this talk to go through the details of each of these tests, but I'll use the Exodx test to illustrate what could be accomplished using these tests. So the Exodx test queries urinary exosomes for 3 genes, PCA3, SPDEF, and ERG. Compared to basic clinical parameters such as PSA and digital rectal exam testing and race, etc., the Exodx test includes the area under the curve for this test to roughly 0.77. And when we look at those 4 tests that I had mentioned previously, all of their area under the curves range from roughly 0.7 to some even up to 0.9 in comparison to PSA, which offers an area under the curve of only 0.5. So we have really an embarrassment of riches. We have 4 or 5 really great tests that help improve the specificity for prostate cancer screening. How do we choose one of those tests? Well, there's no comparative data to do so. There was, however, a paper in the Journal of Urology which took the diagnostic performance of these 4 tests and added in the additional information of what the average costs of those tests are in 2018 in the United States, and drew some comparative effectiveness information from that. Well, in looking at the 4 different tests, what we come to learn is that they're very, very sensitive to the pricing of the test. If we look at the probability for cost effectiveness, the less constrained we are in the amount of money folks are willing to pay, the more similar the tests perform. However, the more constrained we are, certain tests really emerge as the ones for preference, including the Select MDX test. As sort of a moderate restriction, we see the Select MDX test and the EPI test really outperform the others. So where does multiparametric MRI fit in? Well, we really don't have tremendous guidance on that either. We do know that the NCCN recommends a prostate biopsy or at least further evaluation for men with a PSA greater than 3 or men greater than 75 for a PSA greater than 4. What they tell us, though, in very vague terms, is to consider a biomarker that improves the specificity of screening and consider multiparametric MRI. If we zoom in further on their recommendation, what they're really saying is the probability of higher grade cancer may be further defined utilizing the PHI test, the Select MDX test, the 4K score, and the Exodx tests. The extent of validation of these tests, however, is unknown across diverse populations, and it is not yet known how such tests could be applied in optimal combination with multiparametric MRI. So not that much guidance. I will, though, however, tell you how I use these tests in my practice. Well, I conduct PSA screening, as many of you do, and then I risk stratify patients by the presence of a PSA less than or greater than 3. Patients with a PSA less than 3 go on to simple surveillance. Patients with PSA greater than 3 then undergo a urine or serum biomarker. How do I choose the marker? Well, it's really based on what one patient's insurance plan covers. Here in the state of Maryland, we're lucky that one of our largest insurers, Care First, has carved out nice coverage for the Exodx test, so that's one that I use quite commonly. If that test is abnormal, then I go ahead and perform a multiparametric MRI of the prostate and perform the biopsy regardless of those findings because of the abnormal urine test. The MRI in a positive case helps me guide a targeted biopsy, and in a negative case, I simply perform a systematic biopsy. If the test is normal, then I simply move on to surveillance. So in conclusion, PSI is a highly sensitive test. However, it has fairly low specificity. There are a number of tests on the market which augment our ability to detect clinically significant prostate cancer, and those include 5, 4K score, Select MDX, and EPI. Based on cost effectiveness analysis, Select MDX and EPI appear to be the preferred tests, and future work must focus on how to use these tests in combination. With that, I'd like to say thank you, and I look forward to hearing the other talks during the session.